Hello, everybody. My name is Michel Slama. I am the head of the ICU unit in Amiens in France. And I would like to discuss with you about the hemodynamic impairment in relation with the ARDS. You know that during the ARDS, you may have associated an hemodynamic impairment due to a positive mechanical ventilation, to high PEEP, to recruitment maneuver, as well as due to hypercapnia, septic shock associated with, and the fluid management, of course. Let me show you that the positive mechanical ventilation may be associated with an hemodynamic impairment during ARDS or even without any ARDS. And it is well known for a long time that when you apply a positive pressure ventilation, and here it's an old paper in which they increase the PEEP, then they increase the pressure into the lung from 0 to 20 centimeters of water, the pressure into the right artery increase, but in contrast, the transmural pressure into the right artery decrease. So it means that during high pressure into the lung, so you have a decreased venous return, and then you induce and decrease the right ventricular preload. And it is true in this study in normal dogs as well as in ARDS-induced dogs. So that's the first point. The second point is that when you increase the pressure, the positive pressures into the lung, into the chest, then you increase the pulmonary arterial systolic and mean pressure, and then you increase the afterload of the right ventricle. Then mechanical ventilation may induce an hemodynamic impairment due first to a decreased venous return, and secondly, due to increased afterload of the right ventricle. And if you increase the afterload of the right ventricle, you may induce what we call an acute cor pulmonale during ARDS, and you have a good, very nice imaging on echo on the right-hand side of the slide. You see that you have a very big right ventricle due to a pulmonary artery hypertension, big right atrium as well, and this big right ventricle compress the left ventricle, inducing a diastolic dysfunction of the left ventricle. And as well, due to the systolic inversion of the pressure gradient between the right ventricle and the left ventricle, you may have a paradoxical septal movement with what we call a D shape of the left ventricle. And so the acute cor pulmonale could be associated with ARDS in up to 50% of cases, as it was well demonstrated in this study. But the problem is that the acute cor pulmonale is associated with a bad prognosis of patients with ARDS, and more severe is this acute cor pulmonale, more the mortality is high in patients with ARDS. So the mechanical ventilation may induce by itself acute cor pulmonale and then hemodynamic instability. High PEEP may be involved as well in this phenomena. Usually PEEP improves patients with ARDS by increasing the PF ratio, by decreasing the time to unassisted breathing. But unfortunately, the high PEEP may induce a right ventricular dysfunction. And look at this recruitment maneuver with a PEEP of 25 centimeters of water. The right ventricle is normal, but in contrast, when we increase the PEEP to up to 35 centimeters of water, we induce a dramatic increase of the right ventricular size with a compression of the left ventricle, which induces a decreased cardiac output and an impairment of the hemodynamic in patients with ARDS. We did this study in 18 patients with moderate to severe ARDS, and in which we analyzed a surrogate of the systolic function of the right ventricle, which is a longitudinal strain. And you see that when we increase the PEEP from 10 to 25, we induce a right ventricular systolic dysfunction. So high PEEP may induce hemodynamic instability by itself and may induce cardiac dysfunction as well. the recruitment maneuver, which is very useful to increase the oxygenation of the lung. You see that by increasing the PEEP, so we decrease the collapsed tissue, lung tissue, and we improve the P on F ratio. But unfortunately, it was well demonstrated by Marcello Amato that in this ART study, that if we apply a lung recruitment and if you titrate the PEEP very high, so we may increase the mortality of patients with ARDS. And it is mainly due to an impairment of the hemodynamics. And you see that a need for commencement or increase of vasopressor or hypertension is very high in the group with a lung recruitment maneuver with a PEEP titration, high PEEP titration. And so it means that when we do the recruitment maneuver, and we demonstrated that in this study analyzing 20 patients, when we apply a recruitment maneuver, we increase the size of the right ventricle. But after recruiting the lung, so after that, even if we apply a very high PEEP, so we have no dilation at all of the right ventricle, and we move back to the same size at the baseline. So when you apply a very high pressure, you should open the lung before not to have any hemodynamic impairment. And another example, in 20 patients with the assessment of the TAPSE, which is a surrogate of the systolic function of the right ventricle, you see again that the recruitment maneuver dramatically decreases the systolic function of the right ventricle, but after applying a high PEEP after the recruitment maneuver, so look at that, we have the same TAPSE than previously, but with a much higher PEEP than at the baseline. But the recruitment maneuver also not only depress the systolic function of the right ventricle, but depress as well the systolic function of the left ventricle. On the left-hand side, you see that the left ventricular longitudinal strain is impaired during a recruitment maneuver. But again, after titrating a good and high PEEP, so we have no systolic dysfunction of the left ventricle, despite a higher PEEP than we got at the baseline. And this is maybe due to the fact that during the recruitment maneuver, we decrease the coronary perfusion, as it was well demonstrated in our study. And there is here a very important point. You see that in this PARC study, in which they analyze the poor tolerance group, it means that the tolerance of the recruitment maneuver was very poor. You see that the compliance, the respiratory system compliance is high, in contrast with a group in which the tolerance was good during the recruitment maneuver, and here the compliance is very, very high. And we got exactly the same problem, as you can see here, when the patient are responders to the recruitment maneuver, the P on F ratio increased dramatically, but the cardiac output does not change. In contrast with the patient, non-responders patient, in which recruitment maneuver induced a dramatic decrease of the cardiac output. And then how to manage hemodynamics in ARDS patients. First, regarding the fluid management, we know that we have to avoid first hypovolemia, because with hypovolemia, by increasing the PEEP and doing the recruitment maneuver, you may decrease the venous return and then induce an hemodynamic impairment. But in contrast, we know that when we have a very high cumulative fluid balance, we increase the mortality of patients with ARDS. Second point, ventilator settings management. My proposal is, if you decide to give a high PEEP to a patient, and if you don't open the lung before this high PEEP, so the risk is to increase the right ventricular afterload, to induce acute port pneumonia, and then to decrease the cardiac output. In contrast, if you increase the PEEP, and if before you open the lung, then you avoid any compression of pulmonary capillaries, then you have no change of the pulmonary arterial pressures, and then you have most of the time no change of the cardiac output when you set a very high PEEP. If sometimes you may have a slight decrease of the cardiac output, and here it's very simple. You just have to give a little bit of fluid, and you improve the cardiac output. Regarding the catecholamines management, we have very few evidence, but most of the experts advise to use vasopressor as a norepinephrine, as it was demonstrated is in this animal study, improving the systolic function of the right ventricle. But you know that there are many phenotypes of ARDS, and then the hemodynamic impairment will change in these phenotypes, if you have or not a pulmonary or non-pulmonary cause for this ARDS, if you have inflammation, if you have the presence of an acute cardiomyopathy. And so you have to take into your mind that the phenotypes may modify the hemodynamics related to the ARDS. And you are with the ARDS like a man walking on a string, and then if you improve the length, sometimes you may impair the hemodynamics and then increase the mortality of your patient with the ARDS. So from my point of view, in conclusion, mechanical ventilation, you know, everybody knows that may induce severe hemodynamic impairment with hypotension due either to revised ventricular preload or to increase the rise ventricular afterload. The hemodynamic effect of mechanical ventilation, PEEP, recruitment maneuver depends on previous hemodynamic status, respiratory system status, and as well to ARDS subtype. But opening the lung before applying high PEEP seems really necessary to avoid the impairment of the hemodynamics. And regarding the fluid administration, you have to avoid too positive balance, but as well to avoid a central hypovolemic. Noradrenaline for us seems that it is the best drug to use when acute cardiomyopathy is associated with ARDS and hemodynamic impairment of the patient. And my advice before ending this presentation is to read this expert opinion of the hemodynamic management of ARDS, and you will find all the problem regarding fluids, catecholamines, and respiratory strategy. So thank you very much for your attention during this presentation, and hope to see you later. Bye-bye.